average teen gets more than 10% of daily calories from soda. What's more, restaurant food now accounts for more than 40% of family food budgets. These statistics are of grave concern to our next guest, who says childhood obesity has reached epidemic proportions. Let's take note with William Dietz, pediatrician and head of the Centers for Disease Control's Division of Nutrition and Physical Activity. Thanks so much for joining us.
It's a pleasure.
You have been working with the CDC for the last 5 years after nearly 25 years as a pediatrician. Give us an idea of what's the scope of the problem of childhood and adolescent obesity.
One of the reasons I moved to the CDC was because I thought this was a problem that demanded national attention. Between 1980 and the year 2000, the prevalence of overweight children in the United States doubled, and the prevalence of overweight teenagers tripled. This is a problem that's epidemic in both children, adolescents, and adults, and I think it's the most significant health problem facing the United States today.
And many say it's a neglected health problem, that we aren't paying enough attention to it, and that the long-term consequences are something that we'll all feel.
Mm-hmm. Well, the awareness of obesity as a problem is new, so it's not a surprise that we don't have well-crafted solutions. But I think there's an acute awareness of how important it is to develop those solutions. This is already an expensive problem. In 1995, it accounted for about 5% of national health care expenditures. And the problems associated with adult obesity, like heart disease, cancer, diabetes, are clearly expensive problems, and that expense is only going to grow.
How did childhood obesity come to be a national epidemic, in your opinion?
Well, that's a difficult question to answer because we don't have good prospective data. We don't have data from 1980 that we can compare against data today. But clearly, the rapid increases in childhood overweight can only be explained by changes in the environment. Now, the environment is both complicated and simple. Overweight can only result from an imbalance of what you eat for what you use up. And if we look to both sides of that equation, we can find clues that suggest that obesity is a consequence of both increased food consumption and reduced physical activity. For example, 40% of a family's budget is spent on food consumed outside the home. 11% of a teenager's calorie intake now comes from soft drinks, which include soda and 10% juices. There's more variety in the food supply. Portion size is enormous. All of those factors have contributed to increased food intake. On the energy expenditure side, there are fewer opportunities for physical activity. Physical education in our schools has been eliminated. The two statistics which I spend a lot of time thinking about are that only a third of children who live within 1 mile of school today walk to school. That's quite different than when we were children and when everybody walked to school. Secondly, although 25% of all the trips we make are less than a mile, 75% of those trips are by car. And I think those statistics reflect differences in the structure of our communities, that we no longer have central schools to which children can walk in many parts of the country. Atlanta is a notable example. We also don't have central shopping facilities or post offices or banks that people can walk to as part of their everyday life. So in effect, what we've done is to increase our food intake and engineer physical activity out of our lives.
But in schools, and there are some schools who are alerting parents that their children are overweight, at the same time they're serving fast food meals at lunches, and they've cut out, as you said, physical activity. In fact, when there's a need for budget cuts, gym and phys ed is often one of the first things cut.
Well, I think schools do have significant responsibility and obligation to feed children healthy meals. After all, many children have at least 2 meals a day in school, both breakfast and lunch. And I think schools have got to respond as parents would. That is, schools are responsible for what children are offered, and they need to assure that those choices are healthful choices. I'm very concerned about the elimination of physical education. And I think one of the factors which is driving the elimination of physical education is the increased emphasis on competitive testing. And schools see that physical education is a course that can be negotiated away so that kids spend more time in the classroom. I think that that's a problem because I can tell you from my son's own experience that if he had not had physical education programs, he would have flunked out of elementary school because he, as one of those children who needed to run off that energy. One of the key pieces of data that we lack are data which demonstrate that classroom performance and classroom behavior are affected by physical activity. And I've often wondered whether the increase in the diagnosis of attention deficit disorder reflects the absence of opportunities for kids to be physically active. Because and again, this is all anecdotal, but I believe that children have a quantum amount of energy that they need to use up. And if they don't have opportunities to use that up on the playground or in the gym, they're going to use it up in class by being fidgety and inattentive. But I think if we had data which demonstrated that classroom performance and classroom behavior were affected by physical activity, I don't think schools would be as eager to eliminate physical education as they've been.
What is also interesting to me is what schools often say about why pizza and chicken nuggets and all of those things are on the menu. The claim is, well, that's what the kids will eat, and if we don't serve that, they'll go elsewhere for it. How do you feel about that?
I think that schools have an obligation to act in this sense as parents around feeding issues. Now, if you ask children what they want to eat, what child is not going to say, I want
chicken nuggets?
Exactly. And there are two solutions to that problem. One is that you can serve chicken nuggets which are deep fried, or you can serve chicken nuggets which have been baked. And the caloric content of those is quite different, and the taste may well be the same. But that depends on the awareness of the school food service director to make those choices and to demand those products from the vendor who's marketing those products to schools. The second solution is that it is possible to change children's preferences within cafeteria lines. There's been a very nice study which shows that when you subsidize the cost of fruits and vegetables and make them attractive, children and teenagers will eat them. Now, subsidizing the prices of those is not a sustainable strategy. But we've shown in another study that if you increase the price on the less healthful alternatives, you can continue to subsidize the fruits and vegetables, show the same impact on consumption, and it's revenue neutral. That is, the bottom line remains the same. So I think these are strategies which are no-cost strategies that clearly impact children's eating habits and need to be implemented in more widely than they have been.
Now, the CDC has begun to address this problem, but you say more time and more energy needs to be devoted to this issue. Is this catching on? Are some of the things you're talking about catching on at schools across the country?
Well, I think there has been an extraordinary growth in the awareness of obesity as a problem. For example, yesterday morning I was in Charleston, West Virginia at an obesity summit, which was initiated and addressed by the governor of West Virginia. I think that's an extraordinary development and reflects the heightened concern about this problem that I see around the country. About 10 or 12 states recently have had obesity summits. Some of them have focused on childhood obesity, others have focused on obesity across the population. So I think that awareness is growing. What I think we lack are solutions that can be widely implemented, particularly at the community level. I think our understanding of this problem and how to affect it is growing rapidly, but we still have a long ways to go.
And in fact, you're heading to Geneva later this week to a World Health Organization meeting, and you well know that the World Health Organization just listed as one of the top 10 global health risks obesity. There are more than 1 billion obese people in the world and 22 million kids under the age of 5. So we're talking about something that's not just affecting us here in the U.S., but elsewhere.
Everywhere we have data, prospective data, we can show increases in the prevalence of obesity, both in adults and in children. And the challenge is to understand globally what's driving this epidemic. And I think that's a key research goal for people across the world.
We also know that if a child at 6 is overweight, that they'll have a 25% chance of being overweight or obese as an adult. If they're overweight by age 12, that increases to 75%. How important then is it that we prevent young people from becoming overweight in the first place?
I think it's very important. Although only about 25% of adult obesity begins in childhood, obesity which begins in childhood is associated with much more severe adult disease. The average body mass index, which is the measure we use to determine adult obesity, of a child who has early onset is over 40. That means that childhood onset obesity is associated with the most severe obesity in adulthood. A BMI greater than 40 is 100 pounds or more overweight. And in the adult population, that severe form of obesity is what is increasing most rapidly. And we have data that suggests that what's driving that rapid increase of severe obesity is childhood onset disease that's lasting into adulthood.
And in fact, physicians are seeing the onset of disease in children as young as 6 or 7.
Well, the risk factors for disease are certainly present. Among overweight 5 to 10-year-olds, 60% have at least one additional heart disease risk factor, like elevated blood pressure, elevated insulin, or elevated cholesterol. And 25% have 2 or more of those risk factors. Those risk factors become the diseases in adulthood of hardening of the arteries or heart disease or diabetes. The biggest concern in the pediatric age group and the most radical development associated with overweight is the increased frequency of type 2 diabetes. This is a disease that was rare 20 or 30 years ago. People almost never saw type 2 diabetes in teenagers. But today in some cities in the United States, type 2 diabetes accounts for almost half of all new cases of diabetes. This, I think, is the best indication that the diseases of obesity are now beginning to occur in early childhood, and I think emphasize the need to focus on preventive efforts there.
One expert says no one should accept obesity in children unless there is a proven medical reason. If something isn't done and soon to reverse this trend, what do you see as the future of America's overweight children?
Well, as I said, I think there's going to be more severe disease in adulthood, and already obesity is consuming a lot of our healthcare dollars. That's only going to increase, and unless we restructure the healthcare system, it's more fairly called a disease care system that cares for the complications of obesity, we're going to spend all our money treating the complications of this disease and not enough to prevent it.
We know that obesity runs in families, but parents provide not only genes but also environment. How important are the two?
Overweight always results from an interaction of genes and environment. I think the most important way to think about genetics is that genetics accounts for a susceptibility to being overweight. It doesn't cause overweight. It's the interaction of that susceptibility with an environment which promotes increased food intake or reduced activity that results in overweight. We can't change genes, and in fact, medications that are going to be used and developed to address genetic differences are likely to be a terribly expensive answer to this problem and may not be terribly effective. For example, the current drugs on the market only account for about 5 to 10% weight loss and cost about $1,100 a year. In my view, that's an expensive solution, and if you run the numbers, the cost of medications is about the same as the cost of the disease of obesity. So I think right now it's not a cost-effective solution. That means that we need to continue to focus on the environment and identify the factors which increase food intake and reduce physical activity. Those factors in a family environment, I think, are regulated by parents.
And in fact, the most successful weight loss programs are a family affair.
Right. It's quite clear that children and even teenagers are not responsible for what foods are purchased, what foods are in the home, how they're prepared. And I think parents in early childhood play a very important role in regulating the susceptibility to overweight. For example, we know that breastfed children tend to have a lower frequency of childhood overweight than non-breastfed children. So the first step occurs when parents decide how to feed an infant. And clearly, I think we need to not only increase the rate of breastfeeding, but also to increase the duration of breastfeeding. Both factors affect susceptibility. Secondly, when those children become interactive with parents and begin to request foods, it's very important that parents follow the rule that they're in charge of what children are offered and children can choose to eat it or not.
So you don't have to clean your plate, and you don't have to finish the entire bottle.
Right. Well, I'll come back to that in a minute. But this issue of choice, I think, is terribly important. And most parents, for example, or many parents, I should say, will come home and say to their child, "What do you want for dinner?" Well, that concedes the choice to the child. Now, if the child says, "I want to go to a fast food restaurant," and the parent doesn't have that in mind, an argument's going to emerge. What the parent should say is, "Tonight we're going to have either hamburgers or chicken for dinner. Which would you prefer?" The other important piece of this feeding relationship is that parents are often concerned if children don't finish what they're offered, and so ask them to eat a little more or clean their plate. That implies that parents have a better idea of what children need than the children themselves. And work here at Penn State has demonstrated that children who are allowed to consume what they think they need without parental interference are much more capable of regulating their food intake than children whose parents decide how much the child should eat. The other concern is that parents are often will say, you know, if my child doesn't eat what I offer, they're going to go to bed hungry. And my view is that's exactly the point. You want children to understand the consequences of not eating. And I think that same principle applies to fruit and vegetables, that parents often force their children to eat fruits and vegetables, knowing that fruits and vegetables are good for them. The more pressure a child feels to eat, the less likely they are to do so. So if you want your child not to eat peas, you insist that they do so.
But speaking of regulation and research at Penn State, there have been studies on portion sizes and the impact it has on how much we eat, whether we happen to be overweight or normal weight.
Those are very important studies, and it's been shown here that young children who are offered increased portion sizes continue to eat the same amount of food. But older children and adults who are offered increased portion sizes increase their intake in proportion to the increase in portion size. Now, we don't have population-based data to support this, but that would suggest that the increased sizes of portions that were offered in restaurants increase food intake, and a major strategy ought to be focused on how to teach people what the appropriate portion size is.
And what responsibility does the food industry have for all of this?
Fast food industry does what they do very well. They offer us inexpensive foods that are readily available and very tasty, and you always know what you're going to get. And that caters to a need in our society. Now, it's unlikely, in my view, that mothers are going to go back to spending 45 minutes to an hour preparing dinner for their families. Therefore, the fast food industry has to play a role in, as it does in today's world. The difficulty that I see is that the alternatives within fast food choices are pretty limited, and they tend to be high-calorie foods. I think the response of the fast food industry and the direction that the industry now seems to be moving is in providing healthier alternatives. And I think it's up to us to make sure that there's a market for those alternatives. You may remember the McLean burger that was introduced by McDonald's 15 years ago, which fell flat. And although McDonald's admits that it didn't aggressively market this product, it's used as an example for what happens when industry tries to be responsible to health needs. Part of our responsibility is that if the industry offers low-calorie products, again, as I think it's likely to do, public health and those interested in this problem really have to create a market for those products. And as I said, I think there's going to be a logical place for those products because I don't think we're going to go back. We're not going to turn the clock back 20 years on the preparation of foods.
I want to go back to what you just said in just a moment, except that you said fast food fills a need and provides inexpensive food, although we're finding that American families are spending as much as 40% on their family food budget on fast food.
On food consumed outside the home. Now some of that's fast food. A lot of that food may be food purchased in a supermarket from the deli counter, but quick service. And there is obviously a market for those foods. The problem is that the healthful choices are not easy choices. And I think as a general public health strategy, we've got to make healthful choices easier choices than they currently are. That applies to things like vending machines.
Which are in schools.
In schools. And there are strategies to modify what's in vending machines. For example, the town of Ann Arbor negotiated a $4.8 million contract for 7 years with a vending machine, or one of the
Vendors.
soft drink companies. But the stipulations that Ann Arbor put on that contract were that there be no vending machines in elementary schools, that the vending machines in middle schools be stocked only with water and 100% juice, and those in high schools were stocked with what you might expect. And interestingly enough, the contract was negotiated. This was not viewed by the soft drink manufacturer as a loser, and water has become the most popular beverage consumed out of those machines. Another good example is what's happened with flavored milk. For a long time, milk was not put in vending machines because people couldn't figure out how to package it. And now some very creative marketers have learned how to package flavored milk. And in several school systems where that's been introduced, it's become the most popular product. I think that we need to be creative about this with respect to fruits and vegetables. I know a lot of people would love to be able to get a fresh apple or a fresh banana out of a vending machine. Part of the problem there is packaging. How do we package it so that it lasts and you know, slides out of the vending machine without being bruised and is still a tasty fruit? And I think the fruit and vegetable industry is beginning to think in those terms as well.
Now, the East Penn School District in Macungie, Pennsylvania made national news when the Director of Pupil Services sent letters home to parents, letting parents know that their child was overweight. And the rationale was, we alert parents that their child has a hearing or vision problem. We alert them when they have scoliosis. We should also alert them that they're either overweight or underweight. The backlash to them was, yes, but at the same time you're serving unhealthful foods and you have vending machines with high-calorie sodas and treats, but they're starting to do what you said. How widespread is that, and how do you feel about that kind of a strategy, alerting parents by letter, let's say, that their child is overweight?
Well, overweight is a health problem. It's not a cosmetic problem. And schools, I think, have an obligation to alert parents to potential health problems. I think the backlash in that community occurred because schools did not acknowledge that they were part of the solution. And the inference was that it was all the parents' fault or it was the parents' problem. But you're absolutely right. Schools provide 1 to 2 meals a day to their students. Schools offer the opportunity for physical education programs. Schools are the locus for the opportunity for kids to walk to school. For example, in Marin County, California, where there was active promotion of kids walking to school, there's been a 50% increase in children who walk or bike to the schools there and a reduction in the traffic around schools. Schools have got to be part of the solution. And if they don't indicate that they're part of the solution, then parents are going to feel blamed and are going to react the way they did in Pennsylvania with a lot of concern and anger at the school for putting out this information. The other part of this that I think schools have to be very careful about is that overweight children, despite the fact that there are many more today than there were 20 years ago, are still a highly stigmatized group. There's a lot of discrimination throughout the culture against obesity. And when schools put out this note, they run the risk of further stigmatizing a group that's already stigmatized. And so I think this has to be done with a lot of sensitivity. And I think that certainly the example here in Pennsylvania raised that consciousness about it.
We have just a couple of seconds remaining, but the CDC, and you've been at this for 5 years now, how optimistic are you that there will be the political will to really tackle this problem?
Well, our budget has increased 20-fold in the last 5 years. And I think there's an awareness among policymakers that if we don't do something about this problem, it's going to swallow our healthcare dollars. For example, Medicaid expenses, which already account for 20% of a state's budget, are going to increase further. If we don't do something to prevent this problem, it's going to bankrupt us.
And on that note, we're out of time. Thanks so much for being with us.
Pleasure.
Our guest has been Dr. William Dietz. He's a pediatrician and head of the Centers for Disease Control's Division of Nutrition and Physical Activity. For Take Note, I'm Patty Satalia.
A copy of the program you've just seen can be purchased through Penn State Media Sales at mediasales.psu.edu or by calling 800-770-2111.